Imagine taking the exact same cutting-edge blood-spinning therapy used to heal a professional athlete's torn knee ligament, but instead injecting it directly into the most sensitive tissues of the female anatomy.
Oh, yeah, it's quite the visual.
Right. You take the biological mechanics of sports medicine and just, apply them to female intimate wellness. And when you look at it through that lens, all that glossy, soft-focused wellness marketing we usually see online suddenly feels a bit, well, inadequate.
Massively inadequate, yeah.
Because we are looking at a physiological landscape that involves needles, blood, and a very real recovery process.
Okay, let's unpack this. You sent us a fascinating stack of sources for this deep dive.
Really incredible sources, I have to say.
Yeah, they cover everything from aesthetic clinic guides and clinical FAQs right up to the official British Menopause Society practice standards. We are investigating the O-shot, the orgasm shot, but specifically, we are cutting through the shiny brochures to answer a really practical, on-the-ground question for you today.
Right.
Is swelling, bleeding, or bruising actually normal after this procedure? It is such a critical question to answer. I mean, wellness marketing relies so heavily on those spectacular end results. The rejuvenation, the restored function.
The after photos.
Exactly. The reality of the biology gets edited out entirely. If you don't understand the physical mechanism of the treatment, the natural healing response can feel like a severe complication.
Like something has gone horribly wrong.
Right. Patients are often totally caught off guard by the messy reality of how the human body actually repairs itself.
So let's just rip the Band-Aid off immediately. Before we get into the cellular science of what this shot actually is, let's address the immediate aftermath.
Okay, let's do it.
If someone walks out of a clinic after getting the O-shot and they look down and see bruising, swelling, or minor bleeding, should they panic?
Absolutely not. The clinical sources are incredibly emphatic on this point. Mild swelling, spotting, redness, and a localized sort of pinching sensation. They are entirely expected.
Okay, wait.
They are the standard physiological hallmarks of the procedure.
Wait, I need to stop you there, because we are talking about injecting fluid via a needle directly into the clitoris and the anterior vaginal wall.
Yes.
Anatomically, that is one of the most nerve-dense, sensitive areas in the entire human body. So how on earth is this marketed as a lunchtime procedure with no downtime? That sounds like excruciating trauma, not just a casual midday appointment.
Well, what's fascinating here is the massive disconnect between aesthetic medical terminology and human anatomy.
Okay.
In the clinical world, no downtime simply means no general anesthesia, no intubation, and no mandatory hospital stay.
Ah, I see.
Yeah, it implies you are physically capable of walking to your car and driving home. The pain during the actual procedure is managed with really robust topical numbing creams and local anesthetic blocks. But no downtime does not mean your tissues haven't been profoundly disturbed.
Right, so the numbing cream gets you through the appointment, but it doesn't prevent the biological trauma of the puncture itself.
Exactly.
Yeah.
You are dealing with highly vascular tissues. The clitoris and the vaginal walls are incredibly rich in blood vessel networks. Mechanically speaking, anytime you introduce a sharp needle into a dense vascular bed, you are piercing tiny blood vessels.
So you were going to bleed.
You are going to bleed. Furthermore, you're introducing a foreign volume of fluid into a really tight, enclosed anatomical space.
Like filling a water balloon.
Pretty much. The tissue is literally forced to expand to accommodate that liquid, which immediately presents as swelling.
It's just basic physics. You poke a hole in a blood vessel, blood comes out.
Yeah.
You force liquid into a confined space, the space balloons.
Right.
So what kind of timeline are the sources giving for this immediate reaction? Like, how long does the ballooning last?
The acute phase is relatively short, thankfully. Minor swelling and localized discomfort typically peak and resolve within 24 to 48 hours.
Okay, that's not too bad.
Yeah, and any spotting from the injection sites is temporary, but those first 2 days are definitely a period of active, controlled trauma.
So to really grasp why the body reacts this way and why this controlled trauma isn't a side effect, but the actual catalyst for the treatment, we have to look at what is inside the syringe, right?
We do, yeah.
Because they aren't injecting synthetic fillers like hyaluronic acid or neurotoxins like Botox.
No, not at all. The substance being injected is platelet-rich plasma, or PRP.
Right.
It is a completely autologous treatment, meaning the material is harvested entirely from the patient's own body. The procedure actually starts with just a standard blood draw from the arm.
And we know that blood goes into a centrifuge to separate out the red and white blood cells from the plasma. But let's look at the why and the how of that
Yeah,
concentration.
sure.
Why does simply spinning the blood and isolating the platelets turn it into this potent regenerative medicine?
Well, when you isolate and concentrate the platelets, you are dramatically amplifying their biological signaling capability. Platelets are essentially circulating reservoirs of growth factors, proteins like vascular endothelial growth factor.
Oh, wow.
Right. And in a normal state, they just float through your bloodstream waiting for an injury. When you get a cut, they aggregate at the site, degranulate, and release these growth factors to trigger the healing cascade.
So they're the first responders.
Exactly. By concentrating them often 3 to 5 times their baseline volume and injecting them directly into the vaginal tissue, you are artificially hyperstimulating that exact regenerative pathway.
Okay, so it's like taking your body's natural repair crew, pulling them out of general circulation, condensing them into an elite, highly specialized supercrew, and dropping them directly onto a specific job site. You are forcing the body to over-repair an area.
That analogy holds up perfectly when you look at the mechanics of the microtrauma we discussed earlier. The needle punchers themselves act as the signal.
Right, because there has to be an injury for them to respond to.
Yes. Think of it like aerating a lawn. The mechanical act of piercing the tissue creates microchannels of damage, which alerts the immune system. Then you flood those channels with a massive concentrated dose of the very cells responsible for generating new tissue and synthesizing collagen.
And because this elite repair crew is pulled from your own bloodstream, the safety profile regarding that initial swelling shifts entirely, doesn't it?
Oh, completely.
Like the fear of an allergic reaction or tissue rejection is practically zero because you can't be allergic to your own biology.
That is the crucial distinction. When a patient sees swelling or redness in those first 48 hours, they can be confident it is a purely mechanical and physiological response.
It's just the physical volume.
Right, the physical volume of the plasma stretching the tissue, combined with the intentional inflammatory cascade triggered by the platelets. It is not an adverse chemical reaction.
That reframes the swelling completely for me. It goes from something has gone horribly wrong to the repair crew has arrived, they are taking up space, and the remodeling has begun.
Exactly, it's a construction zone.
But since this localized bruising and inflammation is a necessary part of the cascade, how does a patient ensure they don't accidentally sabotage the entire process? I imagine there are rules.
There are. The clinical protocols are very specific about this, and the most vital warning revolves around pain management. Patients are strictly prohibited from using NSAIDs, things like ibuprofen, aspirin, or naproxen, for up to a week post-procedure.
Now, here's where it gets really interesting. In almost any other scenario, if you have localized swelling, pain, and bruising, reaching for the ibuprofen is like the default first step.
Oh, it's everyone's instinct.
But the sources highlight that NSAIDs actually work against the procedure on two fronts. First, they thin the blood, which exacerbates the bruising at those highly vascular injection sites.
Right. The blood thinning aspect is a risk factor, but the second issue is basically catastrophic to the treatment itself. Consider the pharmacological mechanism of an NSAID.
Okay.
It works by blocking the specific enzymes that produce prostaglandins, which effectively halts inflammation. But the entire premise of the O shot relies on inflammation.
Wow.
The concentrated platelets need to trigger a robust, localized inflammatory response to signal the surrounding cells to start dividing and rebuilding.
So you are chemically suppressing the exact biological response you just paid a lot of money to initiate.
Exactly.
You are sending the repair crew home before they can even unpack their tools.
You shut down the healing cascade at the cellular level. If a patient takes an anti-inflammatory, they neutralize the signaling power of those growth factors. So discomfort management has to rely on cool compresses or acetaminophen, which mitigates pain without interfering with the localized inflammatory pathways.
The post-care protocols also mandate what they call pelvic rest, which again, totally flies in the face of the glossy lunchtime procedure marketing.
Yeah, pelvic rest is mandatory for the first 24 to 48 hours. This involves abstaining from sexual intercourse, avoiding the use of tampons, and pausing any vigorous physical exercise.
Out of the microchannels.
Yes. You have just introduced dozens of micropunctures into the vaginal mucosa and the clitoris.
Right, so it's really about, infection control and just avoiding mechanical stress.
Yeah.
Tampons or intercourse could introduce bacteria directly into those microchannels before they seal.
Exactly. And the exercise component is important too. Vigorous exercise raises your blood pressure and dilates your blood vessels, which would massively increase the risk of turning a minor bruise into a severe hematoma.
A hematoma being a a solid swelling of clotted blood within the tissues. So we've established that a mild localized bruise is the cost of doing business. But the sources are careful to distinguish between expected recovery and situations that require actual medical escalation.
Yes, that distinction is vital.
When does a patient cross the line from normal biological construction zone to I need to call a doctor right now?
Well, patients with underlying blood clotting disorders or those actively taking prescription anticoagulants carry a significantly higher risk for severe hematomas right off the bat.
So they need to be extra careful.
Absolutely. And the guidelines clearly state that symptoms warranting a call to a medical provider like NHS 111 include severe, sharp, or progressively worsening pain. If the discomfort is worse on day 3 than it was on day 1, that indicates an abnormal inflammatory response or a developing hematoma.
The sources also list prolonged, heavy bleeding, the development of a systemic fever, or any abnormal discharge as clear red flags, right?
Yes, definitely.
Because even with the rigorous sterile techniques utilized in clinics, the risk of infection is never absolute zero when you are penetrating the mucosal barrier.
That's right. You always have to monitor for infection.
So what does this all mean? We have detailed a procedure involving blood draws, centrifuges, numbing protocols, needles in highly sensitive areas, mandatory pelvic rest, and a guaranteed period of localized swelling and microtrauma.
It's a lot.
To anyone listening, that is a formidable gauntlet. Why are patients willingly and increasingly seeking this out?
The motivation becomes really clear when we trace the timeline of the cellular benefits. The immediate aftermath is simply the acute inflammatory phase. But once that subsides, the growth factors begin the proliferation phase.
What does that look like?
Over the subsequent 4 to 6 weeks, peaking around the 3-month mark, those signals induce angiogenesis, which is the creation of new blood vessel networks, and neocollagenesis, the synthesis of new, structurally sound collagen fibers. They also facilitate the regeneration of damaged or dormant nerve endings.
The practical translation of new blood vessels, thicker collagen, and regenerated nerves is restored sensation and mechanical function. You get increased natural lubrication because the tissue is healthier, heightened sensitivity, and a measurable reduction in pain during intercourse.
And we really have to look at the massive demographic dealing with the loss of these functions. Your sources included the official practice standards from the British Menopause Society, and the data they present is sobering.
It really is.
Over 50% of postmenopausal women experience severe genitourinary symptoms.
And we aren't talking about a mild inconvenience here.
Yeah.
The BMS outlines symptoms like chronic vaginal dryness, severe irritation, burning, and dyspareunia, painful sex.
Yes.
Furthermore, they note these symptoms don't just peak and fade like hot flashes often do. They can present years after the onset of menopause and persist, on average, for over 7 years. That is a massive portion of the population enduring a profound loss of physical comfort and quality of life.
It is. Now, the standard clinical recommendation from the BMS for these symptoms is topical vaginal estrogen. It is highly effective at maintaining the tissue.
Right, it's sort of the gold standard.
But we must consider the women who cannot utilize hormone replacement therapy, perhaps due to a history of estrogen receptor-positive breast cancer, or those who simply want a non-hormonal intervention.
This is where understanding the mechanism of PRP becomes so important. Topical estrogen works by externally supplementing the hormone receptors to maintain the tissue. But the O-shot approaches the problem by utilizing localized regenerative medicine to rebuild the structural integrity and vascularity of the tissue from the inside out.
Completely independent of systemic hormone levels.
Exactly.
It restores the tissue's innate capacity to lubricate and stretch. But, the benefits extend beyond menopause and sexual function. The clinical sources universally highlight the O-shot's efficacy in treating mild stress urinary incontinence.
Stress incontinence is the mechanical failure of the urethra to stay closed under pressure. You cough, you laugh, you jump, and you leak.
Yes, and it is incredibly common.
So common. Usually after the physical trauma of childbirth or the tissue laxity that accompanies declining estrogen during menopause.
By injecting the PRP into the anterior vaginal wall directly adjacent to the urethra, the resulting surge in collagen production physically thickens and strengthens the surrounding suburethral tissue.
So it basically shores up the foundation.
Exactly. It effectively rebuilds the structural hammock that supports the urethra, allowing it to seal properly against sudden increases in abdominal pressure.
For decades, the options for women dealing with stress incontinence were either exhaustive pelvic floor therapy, medications with systemic side effects, or highly invasive surgical sling procedures. Offering a localized autologous injection that structurally reinforces the tissue is a massive leap forward.
It really is.
Resolving that leakage restores a woman's fundamental confidence to move through the world freely.
It radically shifts the narrative. And if we return to our primary mission for today, is the swelling, bleeding, and bruising normal? Yes. It is an unavoidable, essential physiological response to the mechanical action of the treatment.
Right.
The microtrauma and the volume of the plasma dictate that recovery period.
You just have to respect the biology. You must avoid the NSA so the platelets can actually trigger the inflammation necessary to rebuild the tissue. You must adhere to the 48-hour pelvic rest, and you have to be vigilant for the actual red flags like worsening pain or fever.
Absolutely. And if we connect this to the bigger picture, it challenges us to examine the profound stigma that still surrounds women's health. We began by comparing this to sports medicine.
Yeah, the athlete's knee.
When an athlete receives a PRP injection for a torn tendon, the swelling and the downtime are viewed as the acceptable mechanics of advanced regenerative medicine. Nobody questions the biological reality.
But when that identical science, literally the same blood draw, the same centrifuge, the same platelet cascade, is utilized to restore female pelvic floor function, or to treat the painful reality of genitourinary menopausal symptoms, it is heavily sensationalized.
Oh, intensely.
It gets wrapped in taboo or diminished as a frivolous aesthetic novelty, entirely because society remains deeply uncomfortable discussing the realities of female anatomy and sexual health.
How drastically would our medical landscape change if we consistently framed intimate wellness as standard, necessary regenerative medicine? Acknowledging that restoring a woman's continence, her daily physical comfort, and her capacity for pleasure carries the exact same medical validity as repairing a runner's knee.
It's such a powerful point. When we strip away the glossy marketing filters and confront the complex, highly efficient reality of how our bodies heal at the cellular level, we empower ourselves to make truly informed decisions. Thank you for providing such a phenomenal stack of sources for this deep dive and sparking a critical examination of this topic. Keep demanding the actual science behind the brochures. Keep investigating the biological mechanisms of the treatments you encounter. And most importantly, keep learning. Maybe the most accurate after picture isn't the one showcasing immediate impossible perfection, but the one where the body has been given the biological tools and the necessary time to systematically heal itself.